Okay, so we're talking about pain medications today. Um, so today we are just going to look at the opioids and then the antagonist drugs. So, um, so when we talk about opioids, we are referring to derivatives of the opium plant. So these are pain medications which act like that. So they can either be direct derivatives or synthetic drugs that act or imitate the action of opioids. And these include pethidine, tramadol, morphine, and then opium itself. Because they all have similar mechanism of action, I just decided to take morphine as a prototype. So we are not going to talk about tramadol and pethidine. And then we'll also look at the antagonists. These are medications that are used to sort of counter the effects of opioids. So if there's withdrawal, if somebody has an addiction, we use these antagonists for them. I've decided that because there are so many different subclasses, it would be very exhausting to treat each one. So from now, what I'm going to do is that if we take a class of medications, I'll treat one prototype. So let's say if we take antihypertensives, for example, maybe calcium channel blockers, we'll look at one, maybe nifedipine, and that will be it. Then we'll move on to angiotensin receptor blockers, things like that, so that it doesn't become so exhausting, because ultimately you won't be expected to have all these things in your head. But what is important is to understand how each class of medication works and how it carries out its therapeutic action. As for the rest of the nitty-gritties and those things, you find it in the BNF. So once you have a good BNF, you are good to go. On the other hand, if you have the standard treatment guideline, that also helps. But I find that the BNF has more detail. Okay, so we'll start. So opioid agonists are also called narcotic agonists and include opium derivatives and synthetic drugs with similar properties. They are used to relieve or decrease pain without causing the person to lose consciousness. So contrast this with the anesthetic agents, which can impair consciousness. And they are also used for pain relief. So antitussic means that they suppress cough, and some also have antidiarrheal actions that can control diarrhea. So these ones are used as secondary effects, but their primary effect is for pain relief. Then we also have the opioid antagonists. These ones are not pain medications. They block the effect of the opioid agonist, and they are used to reverse the adverse drug reaction. If you will remember, in pediatrics, we talked about naloxone. And we said that if a mother is in labor and she's given pethidine and she delivers less than 4 hours after the pethidine is given, the pethidine can cause respiratory depression and can suppress the respiration in the newborn. And so once you have that history, you give them naloxone. Naloxone is an opioid antagonist that will block the action of the pethidine and reverse its respiratory depression. So they are used to reverse the drug reactions such as respiratory and CNS depression, which is produced by the opioid antagonist. But unfortunately, reverse this effect. So, for example, if a patient is in severe pain, you put them on morphine or pethidine. and then you realize that the pethidine is producing maybe respiratory depression or CNS depression. Once you give your antagonists, you're also reversing the pain effects of, or the analgesic effect of the pethidine. So the patient's pain will recur. So that's the downside of giving an opioid antagonist. Then we also have mixed opioid agonist antagonists. So they have both the agonist and the antagonist. So the agonist component will relieve the pain, and the antagonist component decreases the risk of toxicity and drug dependence or addiction. And they also reduce the risk of respiratory depression and drug abuse for these patients. Okay, so we are basically going to look at three different classes of medication. We are looking at the opioid agonist, we are looking at the opioid antagonist, which reverse the action of the opioid agonist. And then we are also looking at the mixed opioid agonist antagonist drugs, which comprise of the two classes and are used for pain relief and then also to decrease the potential for CNS depression and then drug abuse. So we have all these as opioid agonists. So morphine, like I said, we always use morphine as a prototype. So it is a standard against which the effectiveness and adverse reactions of the other pain medications are measured. And the opioid can be given by several routes, but then inhalation is uncommon. So it can be given orally, it can be given subcutaneously, it can be given by IV route. The oral doses are readily absorbed from the GI tract. You can also even use transdermal patches. It can be given in the mucosa, and it can also be given intrathecally, meaning into the subarachnoid space, into the cerebrospinal fluid. The once administered IV provides the most rapid pain relief. It's almost immediate, and the pain relief is reliable. The subcutaneous and the IM routes may have delayed absorption, especially if the patient has poor circulation, because you know that for a drug to be well absorbed, you need a good circulatory system to convey the drug from the site of administration to the rest of the body. And that's where the circulatory system comes in. The opioid agonists are widely distributed throughout body tissues, and they have a low plasma protein binding capacity, meaning that they don't readily bind to plasma protein. So a lot of the unbound or the free drug is available in the circulation for action. Now, they are metabolized extensively in the liver, and a lot of them are converted to toxic metabolites. So, for example, meperidine is metabolized to normeperidine, and this is a toxic metabolite which has a longer half-life than the original drug. So, if the patient has liver failure, then it will accumulate. Also, if the patient has renal failure, it can accumulate, and because it's toxic, it can lead to CNS excitation and seizures. So administration of this drug for more than 48 hours will increase the risk of toxicity. And so you hardly give it for more than 48 hours. The metabolites are excreted by the kidney, and then a small amount is excreted in the stool through the biliary tract. So pharmacodynamics, opioid agonists reduce the pain by binding to opiate receptor sites. So you have these receptors in the CNS and also in the peripheral nervous system. Now these receptors are known as mu receptors and then N-methyl D aspartate receptors. So these receptors are located in the CNS and in the peripheral nervous system. So when you give the opioid drug, it binds to the receptors, and then it mimics the effect of endorphins. Now, endorphins are natural painkillers which occur in the body. And so when the opiates bind to it, they would they would um they would produce the analgesic and therapeutic effect just as the natural painkillers or the endorphins would. And when they bind, produce they can also produce respiratory depression and constipation as a side effect. So we'll look at we'll understand why the constipation occurs. So what usually happens is that the opioid agonist would act on the smooth muscle of the GI and genitourinary tracts. So when they act on the GI tract, they cause contraction of the bladder and the ureters. However, in the gastrointestinal tract, they would rather cause relaxation and slow down peristalsis. And it is the slowing down of peristalsis that will result in constipation because you need peristalsis to move the food along the GI tract. So if you have a situation whereby there's slowed peristalsis, it means that the food is going to be stagnant in the GI. And this is what will lead to constipation. So constipation is actually a very common adverse effect of the opioids. And so those in the clinical setting, you realize that if a patient is in severe pain and is on morphine for a long time, we would usually prescribe lactulose in addition. Lactulose is a laxative which helps to obviate the constipation effect of the opiates. Another thing that they do, the morphine does or the opiates do, is that they cause blood vessels to dilate, and especially the blood vessels in the face, the head, and the neck. Another thing they do is also that they suppress the cough center in the brain. And this is where their antitussive effect comes in. So for some of the cough syrups, you realize that they may have some codeine or some morphine in there. A lot of the time it's codeine that you see. And the reason for the codeine is because it has an antitussive effect. So this can also contribute to the side effects. So for example, if the blood vessels dilate too much, you can have hypotension. So let's sort of backtrack to physiology to try and understand this. Now, if the blood vessels dilate, it means that they will be relaxed. So there'll be pooling of blood. So there won't be a lot of blood being carried to the heart to pump out. And this is where the hypotension will occur. So opioid agonists are used to relieve severe pain. So the underlying thing here, or the key thing here is severe pain. And so it's always important to gauge the severity of the pain So severe pain in acute, chronic, and terminal illness. And then it also helps to reduce anxiety before a patient receives anesthesia. And sometimes it can be used to control diarrhea and to suppress cough. And this is taking advantage of the adverse effects of constipation and then also the antitussive effects. Some of them are also used for anesthesia. So let's look at how pain comes about. So we have peripheral pain neurons from the periphery. So maybe from your fingertip or from under the soles of your feet or whatever. These these pain receptors will pick up the pain sensation, travel through the dendrites, and get to the cell body. At the synapse will be in the CNS, and that will be in the dorsal horn of the spinal cord. Now, the neurotransmitter at this synapse is called substance P, and this is the pain neurotransmitter. And this is a neurotransmitter that helps to transfer the pain impulses from the receptors to the CNS, which will then carry the impulse to the brain. So when you somebody is in pain, what happens is that the spinal interneurons respond to the stimulation from the neurons of the CNS and release endogenous opiates. This is what we call the endorphins, which are our natural painkillers. So these endorphins will bind to the peripheral pain neuron to inhibit the release of substance P and to retard or slow down the transmission of the pain impulses. And this is what leads to the analgesic effects. So if you have synthetic opiates, they will mimic the action of the natural painkillers or the endogenous opiates by binding to the receptors on the neurons and therefore inhibits the release of substance P. So that is a way by which the opioids would carry out their mechanism of action. So in patients with pulmonary hypertension or left-sided heart failure, the morphine relieves the shortness of breath by dilating the peripheral blood vessels. So a patient with pulmonary edema, their lungs are congested. They are filled with a lot of fluid from too much blood getting there. So what happens is that when you give morphine, it dilates the peripheral blood vessels and reduces the amount of blood that gets to the lungs, and this will decrease the cardiac preload. So one of the most common adverse reactions is it decreases the rate and depth of breathing. It can cause respiratory depression. If you remember ethics, we talked about the doctrine of double effects. And we were saying that if somebody gives morphine for pain relief, and then it leads to respiratory depression and the patient dies, we were trying to examine the ethics of it. And we said that since it is not the intended aim and it's actually a side effect, then there's no harm done. And this is the doctrine of double effect. So the dosage, the respiratory depression depends on the dosage. So as you increase the dose, the respiratory depression worsens. So actually, the dose of morphine that can cause severe respiratory depression and death will be a higher dose compared to the therapeutic doses. And then in patients who have asthma, it can trigger an asthmatic attack. Other adverse reactions are the flushing. The flushing is from the dilation of the blood vessels on the face. Then the orthostatic hypotension, also from the same thing. Then you can also have pupillary constriction. So the drug interactions, if you are giving a medication that decreases the respiration of the patient or causes some CNS or respiratory depression, then if you are giving it in addition to the opioids, for example, if you are giving it with morphine, then you worsen the patient's respiratory distress. So for example, sedatives, diazepam, for example, if you give diazepam, then this patient will go to sleep for a very long time. Then hypnotics, anesthetics. So you have to be very careful when you are giving these medications. Okay. Then If you are giving medications like tricyclic antidepressants, phenothiazines, or anticholinergics, it can cause severe constipation because these medications cause constipation. Morphine also causes constipation. So when you're giving the two together, you would have a very serious issue of constipation on your hands. Then there are drugs that will potentiate the analgesic effects of morphine, and then drugs that may be affected. So if you have carbamazepine, for example, or warfarin or beta agonists or calcium channel blockers, they may be affected by giving morphine. And then also, if you have all these other medications that are listed, they will affect how much pain relief the morphine can give. Okay, so we look at the mixed opioid agonist antagonist. So these ones, they contain both the agonist and the antagonist. And what they do is that they attempt to relieve pain while reducing the toxic effects and dependency. So examples are what I have listed. Now, the medication pentazocine has pentazocine lactate and is combined with naloxone, aspirin, or acetaminophen for very severe pain. So they have less potential for abuse than the opioids. And patients with chronic pain who are taking opioids shouldn't take the mixed opioid agonist antagonist because there can be a risk of withdrawal. So the medications, once they are given, they are absorbed rapidly and they are given parenterally. They are distributed to most of the body tissues and they can also cross the placental barrier. They are metabolized in the liver, excreted by the kidneys. So the exact mechanism is not known, but researchers believe that these drugs would antagonize the effects of the opioids by competitive inhibition at some receptor sites. Meanwhile, at other receptor sites, they are able to bind to the receptors and cause a pain relief. So this medication usually binds to receptors in the CNS and it alters the emotional response to pain. And it is released slowly from the binding site and produces a longer duration of action than the other medications in the class. So what happens is that they bind to the opioid receptors in the limbic system. And the limbic system is a part of the brain that's involved in emotion. Sorry, let me just answer this quickly. Hey, phone consultation. And it's also, so it's system is what's involved in emotion. So it helps to regulate the awareness of pain in the patient. And this is also one of the ways by which it decreases pain, the sensation of pain in the patient. And then some of them also act on the pulmonary circulation and increases pulmonary vascular resistance. And as a side effect, it can increase the blood pressure and the workload of the heart. So the mixed opioid agonist antagonists are used as analgesia during birth. They can also be given post-operatively. Now, the advantage of using it as an analgesia during birth is that because it has both agonist and antagonist action, it doesn't cause the respiratory depression that can occur in the neonate if the child is born within a shorter period than anticipated. The downside is that these are not readily available in our setting. So we still have to use the pethidine or do epidural for patients in pain. So the adverse reaction, nausea, vomiting, dizziness, sedation, euphoria, lightheadedness. So usually when you have these medications, there is increased CNS depression and then a decrease in respiratory rate if you are also on CNS depressants like alcohol and barbiturate. So you need to talk to the patient about it before you put them on it because of the risk that there could be increased CNS depression. Then there can also be symptoms of withdrawal in patients who abuse opioids because if the patient is abusing opioids, you are giving the antagonist, it's going to reverse the action of the opioids. And if the patient is dependent on the opioids, reversal of the action would lead to withdrawal symptoms. And then they are also listed as pregnancy risk category C drugs, so they are not to be used during pregnancy. And then safety and use in breastfeeding hasn't been established, so it's also a no-no when the woman is breastfeeding. So the last group of medications we'll look at are the opioid antagonists. So these ones are the medications that antagonize the action of the opioids, and they help to reverse the action of an opioid medication that has been given. For example, if a woman has been given pethidine during pregnancy, during labor, and it is causing respiratory depression in the neonates, you give an opioid antagonist to reverse the reaction. So opioid antagonists have a greater attraction for the receptors than the opioids. And what they do is that they block the effects of the opioid drugs on the receptors, as well as the natural painkillers, the enkephalins and the endorphins. Examples of these are naloxone and naltrexone. So naloxone is given IM, subcutaneous, or IV. Obviously, bioavailability for IV is 100%. Naltrexone is administered orally in the tablet or liquid form, and both drugs are metabolized by the liver, and both are excreted by the kidneys. So how do they act? They act by occupying the opiate receptor sites and displacing the opioids, which are attached to the receptors by binding to these receptors, thereby preventing the opioids from binding. And this is called competitive inhibition. So naloxone is used when there's an opioid overdose. It reverses the respiratory depression and sedation. And within seconds after IV administration, it stabilizes the patient's vital signs. So the baby comes in severe respiratory distress, mother has had pethidine, you set an IV line, give your naloxone, within seconds, patient is fine. That's how quickly it acts. Now, the other member of this group, naltrexone, is used in patients who are opioid addicts. So maybe a pethidine addict or somebody who is addicted to morphine. Naltrexone is part of the protocol for managing the addiction of the patient. So you need to follow these guidelines when you are managing such patients. So what you do is that you have to be sure that if there's acute phase of opioid withdrawal, this patient could end up with withdrawal symptoms. So if the patient is receiving an opioid agonist or in the acute phase of withdrawal, you don't give it at that point. So for a patient who is on, let's say, heroin, you have to wait at least 7 days after their last heroin dose before you give the naltrexone. And if it's a longer acting opioid, you have to wait for at least 10 days. So for example, methadone. And when the patient is on the therapy, you have to be alert for the signs of opioid withdrawal. And that is what they call the cold turkey. So drug craving, confusion, drowsiness, hallucinations, lacrimation, and all those other symptoms. Now, naloxone also reverses the analgesic effects of the opioid. So if you gave the too much pethidine because the patient was in severe pain and the patient is now in respiratory distress, and or patient has CNS depression, patient is comatose, and you give naloxone to reverse it, you have to bear in mind that it also reverses the analgesic effect of the opioid. So the patient might actually have pain, or the pain might return. The pain will return after you give the naloxone. So it's important to bear this in mind. Okay. So there are basically very few significant drug interactions. But then the naltrexone will give you withdrawal symptoms if you have a patient who is an addict and is put on it. So that's why you have to wait for at least 7 to 10 days before you put on the naltrexone. The adverse reactions for naloxone: nausea, vomiting, hypertension, tachycardia. An unconscious patient who maybe you have a morphine overdose or pethidine overdose, patients have become unconscious. If you give your naloxone, the patient may hyperventilate and experience tremors. Okay, as an adverse reaction. And then for naltrexone, the adverse reactions are more. You have edema, hypertension, all of these, as well as these. Okay. Any questions? Please, are there any questions? Where are the rest of the class? 13. Any questions? It's becoming too much.
I have a question.
Yes, please go ahead.
I remember when I went for the clinic house, the house officer was about to do an MBA. And she gave, and I said, house officer was about to do MBA. He gave a painkiller. Please, can you hear me?
She was about to do what?
MBA.
What is NPA?
Like
Manual vacuum aspiration.
Yes.
Is MVA. Oh, okay. Yeah. I had N.
It's M.
MVA. Okay, so she was going to do MVA and then
he gave a painkiller. And I can't really remember the painkiller, but after giving the painkiller, the patient started hallucinating, saying certain things.
I'm sure it was ketamine.
Yes, ketamine, yeah. Exactly.
Ketamine has that.
Yeah, so he went to call the And I said, take medicine. When he came, I learned, he said the dose of the ketamine wasn't enough. So it couldn't knock off the patient. So that's why the patient was behaving like that.
Hallucinating. Okay.
Yes. And so he came to give midazolam or something.
Midazolam, don't make
Or something.
I can't really remember the drug.
Hey.
Don't make Cooper.
So, Mr. question. So what's your question?
So I want to know whether it was like an antagonist of the ketamine that he gave.
No. Diazepam is not an antagonist. An antagonist of
it's not diazepam.
Midazolam.
Yeah, like
Yes.
Domicum.
No, midazolam is not an antagonist. What actually happened? I'm sure what she was trying to do was to sedate the patient and calm the patient down, because midazolam is an anticonvulsant which also leads to sedation. It is also used as a short-acting anxiolytic drug or a medication that calms down agitation. So that is why she was using it, not as an antagonist.
Oh, okay.
To calm the patient down.
Kwashigan, why didn't you ask him?
Hey,
And
I don't know.
and our channel.
It's the house officer who did it. And like I said,
It's also
what
procedure.
But when you go for the clinicals, you don't ask any question.
look, that's the question. They disgrace you. They don't like PSO. No.
Hey, why?
No, you need to ask. No, Kutia, the way they disgrace you. Hey, they don't like PSO.
No. Yeah.
You are learning.
Oh.
So you need to ask.
Yeah, no, it's true.
Let me teach you the trick. Let me teach you the trick. Everybody's learning. Everybody's learning, but I confuse approach you with you, man. And I be be able to say now. Okay. That's how it is.
They was sweating, madam.
When you sweat, everybody will